Assalamualaikum warahmatullah. Can you hear me?
Waalaikumsalam.
Hello. Yes, betul.
Okay, I think most of you is already ready. I think why don't we start?
So Bismillahirrahmanirrahim. So we open our session today. Umur kitab Al-Fatihah. So Mimi, you will be the first presenter, right?
Okay. 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 Alright. Semoga nampak ya. Boleh.
Boleh.
Okay, Bismillahirrahmanirrahim. So today I will present, my name is Tuan Nur Syamini. So I will be presenting the bone marrow aspiration and also trophine biopsy. So just to recall, okay. Just to recall what's the difference between aspiration and biopsy. So basically we do aspiration when we want to study we want to do cytology, we want to study the morphology of cells, and biopsy we want to do when we want to examine the architecture and cellularity of a tissue. In this case, we want to study the bone marrow. So what are the indications for bone marrow aspiration and biopsy? So first we have the diagnosis, staging, and therapeutic monitoring of lymphoproliferative disorders such as CLL, Hodgkin lymphoma, and hairy cell leukemia, myeloproliferative disorders. Then we have multiple myeloma. We can also do BMA and also bone marrow biopsy for aplastic anemia, infiltrative infectious diseases, which we can see the etiologic agent in the bone marrow itself. And then we can also do as part of an investigation for fever of unknown origin. So what are the complications of this procedure is, first, we have hemorrhage, which the risk factors are concurrent anticoagulation therapy or underlying myeloproliferative syndrome. We also, second complication is the needle breakage, and third is infection. So for general step for the procedure is, first we want to anesthetize. In children, we generally do general anesthesia, but in adult we can do local anesthesia after preparation of the skin. So then second, we want to position the patient in the right or left decubitus position, like in this picture here, and then we want to locate, we want to palpate the posterior iliac crest and mark the area. So as this figure show, this is we have here the posterior superior iliac spine, so we can try to palpate at the back. So the insertion of the needle would be in the direction to the anterior superior iliac spine. So you need to palpate these two, so you can gauge the direction of the needle that you need to push in. So, and then for the preparation of the skin, we want to apply antiseptic on and also drape, and then we can do skin incision. Okay. In the case when we only want to do aspiration but not do biopsy, skin incision is not needed. But if we want to do both aspiration and biopsy, some small incision is needed. So then, in holding the needle, a more comfortable way to hold the needle is to put the dome in your palm, and then third and fourth finger on the handle and on the transverse handle, and you try to stabilize it using your forefinger. Then you try to insert the needle through the area that you already marked. So you rotate your hand like clockwise, anti-clockwise until you penetrate the cortex. When you when you already penetrate the cortex, you can feel that the lesser resistance. So then you try to remove the stylet. When you remove the stylet, this needle will be hollow. Okay. Then you try attach the syringe to the needle mount. And then you try to aspirate, and then transfer the bone marrow aspirate into the container with anticoagulant. Then you replace the stylet. Okay. So depends on the type of needle you use. Some needle can be reused, or some needle can be single use. So if it's single use, you need to use another needle. Now we want to do biopsy. We already done with the aspiration. Now we want to do biopsy. So when you reinsert the needle, you want to insert in the same skin incision, but you want to reposition the needle, because the earlier part of bone marrow you already aspirate, so you don't want to do biopsy on the same part of bone marrow. So so you want to avoid having aspiration artifact. So the same as earlier, you insert until you feel the bone, and then you here you remove the stylet first, and then you try to penetrate the cortex. Okay, you try to penetrate the cortex, and then when you already penetrate the cortex, you go further deeper, like around 2 cm, so that the bone marrow will be inside the hollow needle. So when you've done that, you want to rotate the needle berulang kali until because you want to loosen the bone marrow. You want to separate the trabeculae of the bone marrow, so that the bone marrow tissue itself is stay inside the needle. So when you've done that, you try to withdraw the needle. You can do that also in the rotary motion to assist with the withdrawal. And then you try to remove the specimen by gently pushing the biopsy. You want to push the tissue, the bone marrow, out from the needle into a bottle. Okay, you can see this more clearly in the video. I'll show you. Okay,
On children. On children. On children, bone marrow aspiration is always done in general anesthesia. The child is placed in the lateral position. The area around the puncture point is disinfected with chlorhexidine and covered with a sterile drape. The biopsies are taken from the upper iliac crest with access via the ventral spine. The needle is pushed toward the posterior iliac spine and rotated with careful pressure until it goes through the cortex. When the needle is in the spongy tissue, the trocar is removed and a 5 milliliter syringe is connected to the needle. 0.2 to 2 milliliters is quickly aspirated for a regular bone marrow smear. 6 to 8 smears are placed on slides. The smears are sent to the lab for fixation and staining. An additional 2 to 3 milliliters times 2 are aspirated for flow cytometry.
This is for biopsy.
Finally, a punch biopsy is taken. A disposable needle is used. The needle is inserted in the same puncture wound and pushed toward the posterior crest. The needle is rotated with constant pressure until it penetrates the iliac crest. Care is taken to ensure that the needle does not slide into an area that is not anesthetized. The trocar is removed from the needle. The rotation of the needle is continued until it has penetrated deep enough into the bone marrow. The spoon is inserted into the needle. The biopsy needle is rotated without pressure in both directions to cut the biopsy loose. The needle with spoon and biopsy is pulled out. The spoon is carefully removed from the needle, and the biopsy is put in fixation fluid using a blunt trocar. The incision is closed with strips and covered with an adhesive bandage.
Okay. This is example of findings that you can see in the bone marrow aspirate. So this is the normal bone marrow aspirate, and this is acute. For example, in acute leukemia, you can see a lot of blast cells. So this is the finding in bone marrow biopsy. So you can see that the architecture of the tissue of the bone marrow itself is intact. So here you can see the trabeculae, you can see the adipocytes, and this is the bone marrow cells. So in leukemia, you can see a hypercellular marrow. So there is less adipocytes, so you see more cells. So this is, for example, another one is a aplastic anemia. You can see hypocellular marrow. That's all for me.
Okay, we continue with the we reserve the question to the end.
Walid, mute mic.
Walid tutup mic. Walid tutup mic.
Kena try OSC ni ke? OSC yang
Walid.
tak tu.
Tak dengar.
So next I will be presenting. Can you guys hear me?
Yes.
So next I will be presenting about the CPR in children. Okay, before that, let's us see some video to get an insight on how CPR are done in children. Kalau tak dengar, beritahu lah.
Today we're going to review BLS for the healthcare provider, for the pediatric patient, for the child. Let's take a look at those skill steps now. First, establish unresponsive. Next, look to wait for about 5 seconds. If this child is not breathing, immediately call a code, get some help. Now, in healthcare provider, 2 rescuer. We're going to attach this child to an AED to see maybe if they are in a shockable. Let's take a look and see what those skills look like, shall we? Hey, kid, you okay? Kid's unresponsive. He's not breathing. Nurse, call a code. Hey, this kid doesn't have a pulse. Hey, get over here with that AED. I'm starting compressions. You go right to 15 to 2.
Place electrode.
AED, sir.
Place electrode. Place electrode. Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm. Check pulse. If no pulse, give CPR.
Kids have no pulse.
Okay, that's all for the drill. So we go for the introduction. Okay, what is the definition for CPR? Or we call it as cardiopulmonary resuscitation. It is an emergency life-saving procedure performed when the heart stops beating. So immediate CPR can double or triple the chances of survival after cardiac arrest. So why is CPR is important? It is for keeping the blood flow active, even partially, extend the opportunity for a successful resuscitation once trained medical staff arrive on site. So usually, cardiac arrest in infants and children does not usually result from the primary cardiac causes. Rather, it is an end result of the progressive respiratory failure of shock. So repeat recognition of the cardiac arrest and immediate initiation of high-quality chest compression and delivery of effective ventilation are critical to improve outcome from the cardiac arrest. So we move into the algorithm on how we do CPR on children. So for your information, there are two types of CPR that can be done, which is single rescuer, and two rescuer. So first, I will explain on, we discussing more first on the single rescuer. Okay, first we need to verify when there is a children that having a cardiac arrest and collapse. So first we need to verify the scene is safe. So ensure this area is safe by checking for hazards such as electrical equipment or traffic. Depends on the environment when the child loss of consciousness. And then we need to check for the child responsiveness. So gently stimulate the child and ask loudly whether he or he is alright or not. And then if the child is unresponsive, we need to shout for nearby help. And then if after we shout for nearby help, we need to activate the emergency response system via mobile device, which means that we need to call 911. And then for the rescuer, we need to look for the breathing or only gasping and check the pulse simultaneously. Like the video said before, it is not more than 10 seconds. If the child has a normal breathing and pulse is flat, so we just need to monitor until emergency responder is arrived. But however, there is no normal breathing, but the pulse is flat, so the responder, the rescuer can provide a rescue breathing, which is 1 breath for every 2 to 3 seconds, or about 20 to 30 breaths per minute. And then he need to access the pulse rate for no more than 10 seconds. And then he need to check whether the heart rate is less than 60 beats per minute, which is the sign of poor perfusion. If yes, the rescuer need to start the CPR. But if no, the rescuer can continue to do the rescue breathing and check the pulse every 2 minutes. If no pulse, the rescuer need to start the CPR. However, if during the checking, the children have no breathing or only gasping, and there is no pulse have been felt, so the rescuer need to do CPR, which is he need to perform 30 compression and 2 breaths. And when the second rescuer arrive, he can do 15 compression and 2 breaths. Use AED as soon as possible and when it is available. After about 2 minutes, if still alone, activate emergency response system and retrieve AED if not already done. And when the rescuer have the AED, he need to letak on the chest for check the rhythm, whether the rhythm is shockable or not. If shockable, give 1 shock, and then resume CPR immediately for 2 minutes. And then continue the advanced life support provider, continue the CPR until the LS, which is the advanced life support provider, take over or the child start to move. If no, the non-shockable rhythm, resume CPR until the LS provider take over or the child start to move. Okay, this is for the one rescuer. And then this is the algorithm for the 2 or more rescuer. Basically, the algorithm is the same, but however, the difference is when there is more than 2 person during the CPR. And during 2 rescuer, the rescuer need only to do 15 chest compression compared to when there is one rescuer, they need to do 30 compression. But if there is 2 rescuer, one rescuer can focus to do the chest compression about 30 compression, 15 compression, and for the breath, it will be handled by the second rescuer. And basically, it's the same. For your information, the 2 rescuer CPR is better because 1% is at the chest performing compression, and 1% is at the egg giving the rescue breath. And so it is not tiring and compared to the one rescuer. So there will be less delay between the compression and the breath. Therefore, it is more efficient and more effective if we use 2 rescuer method. And then we move into the algorithm for the cardiac arrest algorithm. If the rhythm is shockable, such as for example like ventricular fibrillation or periventricular tachycardia, the AED, which is automated external defibrillator, we can give a shock, and then we need to continue the CPR for 2 minutes, and then we need to access for the IV and input-output access, and then we need to after 2 minutes or after 5 cycles, we need to check again the rhythm with the AED. If the rhythm is shockable, we give a shock and then we do CPR. And then the second time we need to give epinephrine or adrenaline every 3 to 5 minutes, and we can consider to give advanced airway. And then after 5 cycles or 2 minutes, we need to check again whether the rhythm shockable or not. And then we give a shock if shockable. And then we can consider to give amiodarone or lidocaine. And we did this CPR until there is ROSC, and when there is a return of spontaneous of circulation. Compared to when the rhythm is non-shockable, or we can see in the asystole or pulsar electrical asystole. So we give epinephrine as soon as possible. Then we continue to do CPR. So check for the IV and IO access. Give epinephrine every 3 to 5 minutes, and we can consider to give advanced airway and capnography. And then we check again with the AED whether the rhythm shockable or not after 5 cycles or 2 minutes of CPR. If yes, we go back to the number 7, which we shock again and give amiodarone. If no, we continue to give CPR. Okay, that's all for me.
Okay, hang on. Before we continue, just a short comment. What is our emergency number? Bukan 911 eh. It's ours is
999.
999. Okay, number one. Number two is actually when we talk about IO needle, it's not input output needle. It's actually, anyone knows? Intraosseous needle, right? Hopefully you can after this try and look what is intraosseous needle. Okay, we continue with the next one before you Q&A.
So I will be the next presenter for today. So can you hear me? Yeah.
Yeah.
If you can't hear me or you can hear the video, please tell me. So my name is Fatina Jihad binti Amir and I will be presenting for CPR in infants. So CPR in infant is CPR at birth for the patient at birth to 12 months old. So first, let's watch the video to get some overview.
Aku tak dengar.
Tak dengar? Macam mana? Wait Kamu dengar tak?
Tak dengar juga.
So okay lah.
Pakai speaker.
Ya?
Pakai speaker. Cabut headphone.
Tak, memang guna speaker. So okay lah, kita proceed.
Hold on, could you directly try, because I think you inserted the video link to the PowerPoint. Could you
Yes.
go into your own browser and then try to could you share your browser direct browser from YouTube? Is it from your
This one, like this.
PowerPoint?
If you can see this.
You try and see whether can you hear the voice? Try.
Here. Can you see the YouTube?
Yes.
No. But I already. Dengar ke? Tak. Oh. Tak dengar juga
No, new. If you unmute your microphone and continue playing your own phone and try to play.
I unmute mic.
Yes, you mute your own mic and then play this. Can you hear it? Ada. If you continue. Anyone else? Anyone else has a browser and
May I
with the presenter? You got the link and then try to use your other people.
Haris, can you ada ni ke?
You got a link? Try to use the link. Oh, okay. All right. Okay. Listen to this first. Okay.
Welcome to today's video on healthcare provider BLS for the infant. Let's take a look at what those steps look like, shall we? Hey, Doc. Yeah. Who throws a baby? Step 1, establish unresponsiveness. 2, assess for breathing. If this infant is not breathing, call a code immediately, get some help coming. You're a cutie. And you're unresponsive. And you're not breathing. Nurse, call a code, I need some help in here. Next, check for a pulse. You check for no more than 10 seconds. If this infant does not have a pulse, immediately begin chest compressions. For a pulse? I got no pulse. I kingdom for 2 nurses right now. There goes my kingdom. I need you guys to take over CPR on this little one. You ready? Now, in 2 rescuer CPR for the infant, the way we perform compressions is with a circumferential grip. Our thumbs on the sternum between the nipple line, and we're going to compress about 1/3 the distance anterior posterior in this kid's chest. So almost halfway through this kid's chest, you're pushing. Again, at a rate over 100, and a compression to ventilation ratio of 15:2. Okay, remember. We're going to do our compressions 15:2, 15 compressions, 2 breaths to bear. Watch for that chest rise. Circumferential grip. Remember, you're going to compress about 1/3 the distance through that kid's chest, okay? This is an infant, not a child. Now, if all you have is an adult DVM, you can still ventilate an infant. Take the mask and invert the mask. Turn it upside down. So on the adult, where the nose would normally be, we're going to spin that over. We're going to put the nose section down by the infant's chin. The face mask will then come up and cover the rest of the face. You have to cut down on the amount of volume you give this infant. If we're just looking for a little chest rise, that's all. But again, if all you have is an adult mask, you can still ventilate an infant by inverting the mask.
Okay, thank you, Haris, for helping me. So, CPR in infant. So mostly I will focusing on neonatal. Alright, neonatal resuscitation algorithm according to AHA guidelines 2020. So for introduction, approximately 10% of newborns need help in breathing at birth, and approximately 1% of newborn needs further resuscitation, but mostly do not require immediate cord clamping or resuscitation after birth. So what is the indication for CPR is when the infants have poor response to ventilation or bradycardia, or the heart rate is below 60 beats per minute, and cardiorespiratory arrest. So now I will proceed with the neonatal resuscitation algorithm. It's okay if you can't see this. This is the summarize. So first, at birth, we can see we can check the baby. If the baby is term, good tone, or breathing. If the patient is born term, good tone and breathing, then the infant can stay with the mother. However, if the patient is unfulfilled these three criteria, where either the patient is premature or hypotonia or not crying or breathing. So first we need to warm and positioning the baby, stimulate and clear any visible secretion. So next reflex is we can see if the patient is apnea or gasping. or the heart rate below 10 beats per 100 beats per minute. So if the patient is no apnea or no gasping, or and the patient is the heart rate below 100 and the patient is laboured breathing or persistent sinuses, then we can position and clear the airway, as well as we can check for the SpO2 monitoring, and we can give this oxygen through CPAP. But if the patient is apnea and the heart rate is below 100 beats per minute, we can give the respiratory support through the positive pressure ventilation and the corrective step. Next, you can also give check for the pulse oximetry or SpO2 monitoring, and consider for the ECG. So this step, it must be done in 1 minute. And if in 1 minute the heart rate is still not okay, the condition is not improved and the heart rate is still below 100 beats per minute, then we can do the intubation or direct laryngoscopy and endotracheal suctioning. And if the patient, if after that the patient, the heart rate still below 60 beats per minute, we can intubate if not done, and then we can do the CPR like the previous video. So we can also coordinate with the positive pressure ventilation, give 100% oxygen and ECG. If the patient is not still not okay, heart rate is still below 60 beats per minute, the last option we can give epinephrine, either umbilical through umbilical venous catheterization or intraosseous. So if this step is done, resuscitation done even after 20 minutes, and if the no heart rate or the condition of the baby is not improved, so the survival of the baby is unlikely, and we can initiate the discussion with the family regarding to the decision of resuscitative effect. So in conclusion, so we need to do the CPR. So I just want to recap the CPR step, which is the first one. Like the video, we can establish intact in first 10 seconds, establish the unresponsive nerve, the breathing, and the palpable pulse. If not, then we can do the chest compression. So that's it for me. This is my references.
Okay, before we continue with the last presentation, any question with relation to the previous presentation? Right. Again, all of this actually, again, theoretical. I mean, unless you have a skill lab, it will be in a way, to me, not much useful. So what is your duty is actually, especially for neonatal care and also pediatric care. If you are in pediatric posting, you are in ONG posting, right? Always be alert of when the emergency seizure, whatever indication, whether it's a fetal distress or any form of emergency cesarean section, there will be a medical officer will be attending the delivery. So you should be alert, especially you are on call. You're not on call, probably you will not be alert. Please alert please get the give your contact to the MOHO on duty on that day, right? To call you up when there's a cesarean section. Otherwise, it's almost impossible for you to appreciate or understand the resuscitation. By the way, neonatal resuscitation is a compulsory course that you need to do when you are in pediatric posting during housemanship. So you must pass this before you can do your on-call. While the pediatric F1 life support are usually reserved if you remain in pediatric posting as a medical officer. So you will encounter this again. Then those who have not, I mean, you probably have never seen bone marrow, even lumbar puncture as well. So if you want to see all this action, make sure request for housemanship in the hospital which has these services lah. Teaching hospital usually have this, except UIA lah. UIA you don't have oncology, so that's why you don't have this procedure. Any question before we move on to the last presenter? Okay, no, then I think continue with the last presentation.
Bismillah. Can you see my slide?
Yes.
Okay. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I will be the last presenter for today procedure presentation. We present about electrocardiogram or ECG. Okay, for ECG in children, it's important for us to know the age-related changes in the anatomy and physiology of the infants and children, so that because these are the changes that we can see between the children and the differences from the adult ECG. So the awareness of these differences is the key to the correct interpretation of the pediatric ECG. And most common arrhythmia in children that we can see is BP, bradycardia, and also sinus arrhythmia. And it is important to interpret the ECG in combination with the history and clinical examination, so that we can know that the causes of the ECG abnormality is because of the underlying causes. For example, maybe patient have a reflex, congenital heart disease, or any metabolic derangement that causing the ECG changes. Let's see. Basically, the ECG in children, how to interpret the ECG is the same as in adults. So what I have put here is what are the difference between ECG in children and in adults. So I will not explain more about ECG interpretation, because we will learn more about what the differences in ECG in children compared to adults. So okay, so based on this ECG, which one is normal? So basically these two are both are normal, but the right side is for adult ECG and the left side is for child ECG. So we can see here one of the differences between children and adult ECG is the R interval or the heart rate. So we can see here at the B1 at the leg 2. Okay, so the leg 2 on the left side is the normal ECG of the child. This is a shorter RR interval, which indicates the higher heart rate. Okay, compared to the adult ECG. In the leg 2, we can see the RR interval is longer, because we have a slower heart rate. Okay, so this is the first differences. So we must know the heart rate according to the pediatric age group, but usually for the adult is almost the same if the patient who has typhus or the birth. Okay, so the younger the children, so the faster the heart rate, so the shorter the RR interval. So that is the first one. Okay, the second one, okay, so I think we all know how to interpret the heart rate. So in the regular rhythm strip, we can look here RR interval. So 300 divided by the large boxes. For the left side, 2.5 boxes to divide by 2.5, so we can get 120 beats per minute. And the right side, for the adult ECG, we can divide by 4 because this is the 4 large boxes, so we can get 75 beats per minute. So for irregular rate, we can calculate the number of QRS complexes and multiply by 4. In the normal ECG strip, usually we use 25 millimeter per second, and the volt is 10 volt. Okay, so the second differences is shorter interval. So we can see PR, QRS, and QT interval. These are the intervals according to the pediatric age group. So the right side is the adult one. So we can see here the PR interval, QT interval, and also QRS interval, they are longer, right? So compared to the pediatric age group, the younger the children, so the shorter the intervals that indicates the faster heart rate and the shorter distance to travel and the smaller size type. Okay, the last one is because as we know intrauterine life it is dominantly use the right side of the heart, right? Because of the increase in pulmonary resistance. So after birth, so they will be shifted from the right ventricular dominance in the newborn to the left ventricular dominance about 1 year of age, usually up to 3 years old. The patient the child will have usually dominant R wave in the V1. Compared in the adult, usually they will have shorter R wave. Okay, because in adult taller R wave or dominant R wave indicate something maybe structure maybe cardiac abnormalities, but in adults it's a normal variant. Okay. Okay, so these are the differences due to changes in children according to their physiologic and anatomical changes. So next we will move to supraventricular tachycardia and ventricular tachycardia. So SVT is the most common arrhythmia in pediatric patient, usually asymptomatic. The patient can have palpitation and the rhythm has a rapid regular rate with a narrow KRS complex and often have 280 to 300 beats per minute. Okay, later we will see the management in patient in newborn have SVT. Usually we will do vagal maneuver or if not working, we might administer adenosine or do cardioversion. So next for the VT, ventricular tachycardia is extremely abnormal rhythm in children and rarely seen. And usually if this patient has VT, probably this patient might have underlying cardiac disease, for example, cardiomyopathy, or following some heart surgery with inherited disease. For example, in long QT syndrome, the patient might have episodes of fainting, and Brugada syndrome, the patient might have episode of might be presented with sudden death. Okay, next is sinus tachycardia. It means that heart rate that higher than expected for age. So we must know the table that I presented just now. Okay, the normal heart rate for the pediatric age group. So this is a common finding and it represents normal variation in the heart rate associated with breathing because during inspiration, the heart rate will increase and during expiration, the heart rate will be slower or in other stress response of the body. For example, if the patient is in pain, fever or emotion, so adrenaline rush will increase the heart rate. So sinus arrhythmia is normal and does not require further evaluation or treatment. Next, sinus bradycardia. It means that heart rate lower than expected for age and is common in children with severe distress. And it is the cardiovascular system response to hypoxia and certain drugs. And if the patient does not have any sign of decreased cardiac output, for example, increase in CRP, has cold referees or calming skin, there's no need for treatment. If yes, we might give a support, for example, oxygen support or drugs. Okay, next, we will see the neonatal supraventricular tachycardia emergency. Boleh dengar ke? Tak dengar eh? You boleh terpisah tak?
Tu bagi link.
Pardon?
Link.
Dah bagi dalam grup.
tak dengar.
Video is quite long, about 9 minutes. So please pay attention.
So just for educational purposes, then what we basically did, we started out with ice to the face, covering the nose and the mouth for like seconds, looking for a vagal effect. And we tried that 4 or 5 times without any change at all. It was 291, and Dave's a little quiet.
I'm confirming we're getting 0.3 evidence.
0.3 evidence.
You ready?
Yep, we're ready. Watch the monitor. Watch that.
Please appreciate the changes on the ECG. These are very common that you've seen.
You think it works? It's acting like it. I think, well, wait a minute. I'm back up.
What you think? Give it.
Yeah. What's the rhythm skirt? Read came off.
You want back into it?
Okay. All right. So it was a brief improvement, and then she went back in. So she's back in.
Let me know when to start.
Okay. Everybody ready? Okay. Go ahead. Start. Let's point 6. Go ahead. Start with the.
I will have this start. You ready?
Okay. Go.
1, 2, 3, go.
See it in. Hey, how many done? 89.
It's not 89.
No, I know.
I think that's all.
All right. Okay. Very clear. Any question? So again, among arrhythmia in children, I mean, again, ECG is almost impossible to understand ECG with this 15-minute session. Almost impossible. All right. So you have to sit down and understand again the concept of ECG. And you must be able to read the ECG, especially adult first lah. Very important. Adult first, and then ECG of children is very special. What you need, but you need to know, like the arrhythmia I mentioned, most common is VT and SVT, but SVT is the commonest. You will see this very common in infant SVT, and then I mean if you're managing long-standing thalassemia patient and they are on a blood transfusion, they have cardiomyopathy, they came in with a SVT. This is also very common. I've seen so many prior to this, right? So again, the concept lah. I think you shouldn't be missing. Example, ST STEMI, ST elevation myocardial infarction. You shouldn't be missing that, right? You shouldn't be missing the simple bradycardia. Right? You shouldn't be missing on how to look into the lead A, 2, 3 AVF, 1 AVL to determine this inferior or lateral infarct. Or look at what we want to V6 mean. This is actually a routine. Pediatric ECG is a special in a way, but the reason why I'm actually cutting it to that very specific, because these are the common thing that you see. That's why in district as well, this is a rhythm that you see. Again, if you are somehow in district, some part of your training, there's no specialist there. Again, we have the ECG monitor right just now. Right, you can always start to call up people in the what do you call this, tertiary hospital. Let's say you're working in Jengke, you are not sure. Someone come with a heart rate of 1-20, right? You're not sure. Now with this WhatsApp call, video call, Telegram call, live video call, you can always quickly consult the specialist on DT on that particular hospital, right? So this can I mean, most specialists would be able to help you lah, right? Okay, there will be throughout the training, there will be people especially who hasn't worked in district, you know, didn't understand it. But if you work in district, always ask for help if you are not very clear. Don't worry, there will be support. It's rather better ask for help rather than you lose a patient of by not asking. Okay. Any question? Again, ECG almost impossible. This is very short, almost impossible. I actually intentionally designed it that way because there's no point of covering the whole ECG book in that session. Impossible. Okay, you have to do it yourself. There's no other way by doing what? How? Again, in medical ward, many ECG, and if you go down to ED, you can see so many ECG in ED. So especially in HTA lah, you Temenloh HTA posted there. Even I think UIA also the medical ward full of ECG. Pull up and look and interpret it. Not sure, ask the MO. Okay. Alright, any question? Tak ada. Tak ada, we end up with tasbih kifarah solat asar. Alright, very good. I'll message my email. Kindly what do you call this? Convert it into slides, a PowerPoint slide, whatever. But you don't have to give the link of the video, right? Okay. I think in the future, if you want to put in video in the PowerPoint or Office, I think there's you need to install some software, I think. But I think we know a way. You have to directly open it in the browser. Okay, all right, okay, guys. With that, we end the session. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Salam, thank you, Doctor.
Waalaikumsalam warahmatullahi wabarakatuh.